Welcome to EPG Pathshala. Hi viewers, I am Dr. Alamelu Mangai, Assistant Professor from PG and Research Department of Home Science, Bharathasan Government College for Women, Puducherry. In today's module, you are going to learn about one of the main and the most prevalent disease, that is osteoporosis. Probably you all would have known that the skeletal growth and the strength is determined in humans from the prenatal stage itself, and you need this skeletal strength throughout your life. Your individual weight is also based upon the bone weight. Adequate diet and nutrition is essential for the development and maintenance of bone health. This should be initiated actually from your adolescent period itself, because most of the population, especially older than 65 years, suffer from this most dreadful disease that hinders the productivity and quality of life. Of this disease, it has a most relation to vitamin D and calcium. The deficiency not only causes osteoporosis but also cause osteomalacia. These two diseases have a very complex cause. This module is going to highlight you the condition osteoporosis. You will be able to understand the composition of bones, the calcium hemostatus and its regulation. In this module, you will also learn about the types of osteoporosis, the diagnosis and the role of nutrition in bone, especially along with other medical treatments. It is necessary that you need to understand the composition of bones. Bones consist of an organic matrix or osteoid, primarily the collagen fiber, in which the salts of calcium and phosphate are deposited in combination of hydroxyl ions in crystal of hydroxyapatite. Collagen, which is like a cable with the tensile strength and the hardness of hydroxyapatite, combine to give bone its great strength. The other components for bone matrix include osteocalcin, osteopontin and several other matrix protein. Also, you need to understand the types of bones. The two main types of bones. One is the compact or cortical bone, which is comprised of 80%, where you can see the shaft of long bones, which mainly consist of osteones or Haversian system. The next type of bone is trabecular or cancellous bone tissues, which is comprised of 20% in your body. Here, knobby ends of the long bones, iliac crest of the pelvis, the wrist, scapulus, vertebrae and the region of the bones that line the bone marrows. This cancellous bones are also called as spongy bone or spongiosa. What are the cells that is present in the bone? Commonly, the cells that is present in bone are osteoblasts, osteoclasts and osteocytes. Osteoblasts are responsible for the formation and production of bone tissue. Osteoclasts govern the resorption or breakdown of bone. Osteocytes and bone lining cells, which is actually inactive osteoblast, both of which are derived from osteoblast. The origin of osteoblast and osteoclast is primitive precursor cells that is found in the bone marrow, and you need to know that this stimulate the hormones and the growth factor as a part of their differentiation to become mature and functional bone cells. The calcium hemostatus. Calcium hemostatus refers to the regulation of the concentration of calcium ions in the extracellular fluid. An adult body contains about 1 kilogram of calcium. It is the fifth most abundant element in the human body. The amount of required calcium is age dependent. More calcium is required in growing years. It is responsible for intestinal absorption, renal reabsorption and the rate of bone turnover. For each and every age group, you need the respective amount of calcium requirement, which is specified in recommended dietary allowances for you to understand this homeostasis, that is the calcium balance or bone balance. The bone balance refers to the state of the body stores of calcium at equilibrium over some extended time period. This may range from days to months, and this keep on changing in your life. Balance is determined by net effects of intestinal absorption and excretion by the kidneys on bone calcium, which is a dominant calcium pool. Dietary calcium intake is a major determinant of this calcium balance. Bone mineral content increases throughout your childhood, it peaks in adolescence and remains relatively static in early or late adulthood, and of course decreases in old age. Children have in positive bone balance because bone formation is more than the bone resorption. As formation equals resorption, young adults are in neutral bone balance. The elderly people are in negative balance as they have greater bone resorption than formation. How to overcome this? Exercise, anabolic drugs and anti-resorptive drugs like biphosphonate will promote the bone formation and is associated with increasing bone balance. Similarly, immobilization, weightlessness and sex steroid deficiency lead to negative bone balance. How is this hemostatus of calcium is being regulated? It is regulated by complex interactions of parathyroid hormone 1,2,5-dihydroxyvitamin D and by ionized calcium as well by calcitonin. The main receptors for these hormones are present in the gut, kidney and bone. Calcium hemostatus is regulated through interaction of these hormones that control calcium and transport to the intestine, kidney and bone. Let us understand one by one the hormones. PTH or parathyroid hormone. This is the most important regulator of calcium metabolism. It stimulates the osteoclast and cause bone resorption, leading to rise in serum calcium and phosphorus. This is the one that is going to stimulate the 1-alpha hydrolyse enzyme to increase the 1,25-dihydroxyvitamin D production. Also increases the resorption of calcium in your distal renal tubules, whereby decreasing the calcium secretion. The next component that is very essential for regulation of calcium hemostatus is vitamin D. Vitamin D is synthesized in the skin, but it is also present in the diet. The active form is 1,25-dihydroxyvitamin D. Its main action is to enhance the availability of calcium and phosphorus for new bone formation. Vitamin D is going to enhance your intestinal absorption of calcium as well as phosphorus, and thus it is going to increase your serum levels. Vitamin D also increases the reabsorption of urinary calcium and phosphorus in the renal tubules. The third and the most essential one is calcitonin. This calcitonin is produced by parafollicular cells, also known as C cells, of the thyroid, and is the most important hormone for the calcium metabolism. It lowers the calcium ion levels by inhibiting its absorption by the intestines. The osteoblast activity in the bones and the renal tubular cell reabsorption also is being initiated by the calcitonin. The next aspect that you are going to understand in hemostatus is the feedback loop of calcium metabolism. The aim of this hemostatus is to maintain extracellular ionized calcium levels in the physiological range. This is done by increasing or decreasing the calcium dietary calcium absorption and by the flow of calcium to and from essential stores. In case there is a decrease in serum calcium, then it activates the calcium sensing receptors and causes inactivation of calcium in kidney. Increase might also cause the kidney to increase the secretion of this active form of vitamin D. In turn, vitamin D activates the receptors in the intestine to increase calcium absorption and resorption in the bone. Thus, it becomes an integrated hormonal response to restore your serum calcium. When you have a rise in serum calcium, these actions might get reversed and the integrated hormonal response reduces the serum calcium. When there is low vitamin D3 levels, it also causes osteoclast to release less calcium ions in the blood plasma. Thus, feedback and regulatory mechanisms will help you to maintain total serum calcium within a narrow physiological range. Bone modeling and remodeling. Bone modeling is a term that is applied to the growth of skeletal till the mature height is achieved in an individual. In males, it is completed by the age of 18 and 20, whereas in female, it completes by 16 and 18 years of age. Bone remodeling is a process where bone is continuously reabsorbed through the action of osteoblast and reformed through the action of osteoblast. Let us enter into the mainstream of this module, osteoporosis. What is osteoporosis? Osteoporosis is defined based on bone mineral density, which is abbreviated as BMD, and this might not encompass all the risk factors for fractures, where a fracture-based definition will not enable the identification of a risk population. WHO has resolved this issue by defining osteoporosis in terms of BMD and previous fractures. WHO has classified osteoporosis based upon the WHO study group as BMC and BMD. You can see where the normal mean, the low bone mass and the osteoporosis mean are being mentioned with regard to standard deviation. These diseases of the bone, such as osteoporosis and osteomalacia. Osteomalacia is a condition of impaired mineralization that is caused by vitamin D and calcium deficiencies. As I did mention in the introduction, both these have a complex causes, and the development of these diseases can be minimized by providing adequate amount of nutrient throughout your life cycle. WHO defines osteoporosis in terms of decline of bone mineral density also. In simple means, it is a condition that causes a loss of bone density which result in bones being fragile and more vulnerable to fractures, and the low bone mass is termed as osteopenia. Let us now proceed to the types of osteoporosis. There are 4 different types of osteoporosis. Let us understand the types one by one. The first is the primary osteoporosis. It is a very common type and linked to the normal aging process. Estrogen deficiency is thought to underlie this form of osteoporosis, making your skeletal more sensitive to PTH, that is the parathyroid hormone, and thus resulting in increased calcium resorption from your bone. This in turn is going to decrease your PTH secretion, and there will be decreased secretion of vitamin D as well as with the calcium absorption, and ultimately going to cause you a loss of trabecular bone that leads to vertebral crush fractures and Coles fractures. There is an association between the presence of 2 hormones, estrogen and progesterone, and the rate at which the bone is lost. The estrogen regulates the osteoclast that break down, and the progesterone controls the osteoblast, which actually help in making new bone. Other hormones are also crucial. Although the hip fractures characterize this osteoporosis, the vertebral fractures also increase with age. Wedge fractures of the vertebrae lead to back pain, loss of height, spinal deformity, and kyphosis or Dogger's hump. The primary osteoporosis can further be divided into 2 types. One is primary type 1 and primary type 2 osteoporosis. What is primary type 1 osteoporosis? The type 1 is generally referred to as a postmenopausal osteoporosis, as this is more commonly seen among women. I could say 6 times more frequent who have gone through menopause, resulting in a drop in the levels of estrogen. Primary type 1 osteoporosis actually occurs in women about 10 to 15 years after menopause, usually between the age 50 and 70. The loss of bone structure because of the increase in bone resorption can be connected to estrogen deficiency in women and lack of testosterone in men. This type is also known as high turnover osteoporosis because there is a reduction in the amount of trabecular bone or the inner soft part of the bone. People who suffer from this type of osteoporosis are at the higher risk of spinal and wrist fractures. This is mainly because the loss of bone strength and the reduction in the amount of trabecular bone that is present in the vertebral bodies of the spine and in the end of the long bones like wrist. The next type is primary type 2 osteoporosis. Type 2 osteoporosis, which is also known as senile, is commonly caused by a long-term calcium deficiency. Women are twice as more likely than men to suffer from this type 2 osteoporosis. This results in loss of the outer bone structure and also the inner trabecular bone to wear down and become thin. Many studies have linked the deficiency in dietary calcium and vitamin D as it declines due to age or the hyperactivity of parathyroid hormones, which is secondary to hyperparathyroidism, as one of the risks that can hasten this condition. The primary type 2 osteoporosis is also called low turnover osteoporosis because the rate of bone turnover is much lower in this type of osteoporosis and typically it is going to result in hip fractures. Coming to the second type of osteoporosis, which is the secondary osteoporosis, develops when certain medical conditions and medications is increasing your bone remodeling, leading to disruption of bone deformation. The loss of bone mass occurs due to the imbalance between the production of new bone and the loss of old bone, leading to lower bone turnover rate. Also, an imbalance in hormones from the increased activity of parathyroid glands can result in this type of secondary osteoporosis. This is also common among patients suffering from diabetes. The long-term use of oral corticosteroid can cause hypercorticolism, which increases the chance of developing this particular type of osteoporosis. Disorders lead to the expansion of bone marrow cavity at the expense and can affect your bone strength, leading to osteoporosis. The other causes of osteoporosis also include other medical conditions such as thalassemia, intestinal malabsorption, acromegaly, Cushing's syndromes, to name a few. And it can be due to some other medications such as the antacids and sometimes due to thyroid hormone itself. The third type is Osteogenesis Imperfecta. It is a rare form of osteoporosis that is present in the birth and it causes bone to break for no apparent reason. The fourth type is Idiopathic Juvenile Osteoporosis. This type is too rare. It occurs in children between the ages of 8 to 14 years during the rapid growth. The cause is unknown and there is little bone formation or excessive bone loss. This condition also increases the risk of fractures. What could be the risk or the causes of the prevalence of osteoporosis? As you have understood, it is a complex heterogeneous disorder. There might be many risk factors in one's life. As I have listed, it could be the age, especially older than 60 years, amenorrhea, androgen depletion, cigarette smoking, estrogen depletion from menopause, ethnicity, excessive intake of alcohol, caffeine and fiber, being a female gender, with a family history, inadequate intake of calcium and vitamin, due to lack of exercise, prolonged use of certain medications, sarcopenia, and sometimes due to underweight. All this might prove to be a risk for osteoporosis. Do you have any symptoms for osteoporosis? Typically, many people are not even aware of the condition until the fracture occurs. In some cases, the physical deformity may occur, such as a curved upper back, back from the vertebral collapse in the thoracic spine. However, many patients will suffer osteoporosis for many years completely unaware. There is a relationship between the nutrition and bone with the calcium, vitamin D and phosphates, which is essential for the normal bone structure. Remember, there are also other nutrients which help for bone strength. The premost one is protein. Adequate protein intake along with calcium is essential for optimal bone health. Even before puberty, it is very important for peak bone mass. The theory of higher protein intake produces a higher acidic load which increases calcium urinary excretion, and this theory has to be still verified. The next most important nutrient is calcium. Intake of calcium is the main prevention of osteoporosis. Food sources are recommended as calcium supplement because co-ingestion of other nutrients also might enable for this absorption. The bioavailability of calcium from food source is good. The calcium absorption efficiency depends on the individual need for calcium, the amount of calcium consumed, and the intake of absorption depending on the enhancers or inhibitors. For example, absorption from good food high in oxalic and phytic acid, which is available in certain vegetables and legumes, is much lower than the dietary products. Calcium supplements can also be taken by the individual who is unable to meet the RDA, like that of corticosteroids, and those with low bone mass or osteoporosis, women who are in perimenopausal or postmenopausal, and also who are lactose intolerant. The most common form of calcium supplement is calcium carbonate, which should be taken along with the food because acidic environment enhances the absorption. In the older patient who have achlorohydria, calcium citrate can be supplemented. Then next nutrient is phosphate. The phosphates also are plenty available in almost all foods, but excessive intake can also alter this calcium phosphorus levels. So too high phosphorus will lower the serum calcium concentration. Avoid taking soft drinks because it has poor nutrient, though it might have high phosphorus. Magnesium is the other nutrient. Its deficiency has also got little effect on bone tissues. The deficiency of this may decrease the bone formation, prevent optimal crystal formation, and have a negative effect of PTH. To tell about some of the trace elements, there have been few studies that has found that the effect of trace elements on bone, especially boron, copper, fluoride, iron, manganese and zinc. As you know, boron is used for bone formation by the osteoblast. Copper is required for enzymes that increase the cross-linking of collagen and the elastin molecules. Fluoride ions enter the hypoxyapatite crystals of the bone. Iron is going to serve as a cofactor in collagen maturation. Manganese is going to be helpful for biosynthesis of mucopolysaccharides in bone matrix formation, and zinc is essential for the collagen synthesis. Would you ever forget about the main important vitamin D? Yes. An individual's vitamin D status depends on the exposure to sunlight as well as the dietary intake. Synthesis of vitamin D is by skin exposed to sunlight and also varies on the factors such as skin tone, sunscreen use, environmental latitude and age. The foods such as egg yolk, fatty fish such as salmon, mackerel, catfish, tuna, sardines, cod liver oil and mushrooms are some of the few food sources that has vitamin D naturally. In older adults also, there is increased risk due to the deficiency, probably due to the lesser exposure to the sunlight or increased body fat or the decreased renal function, or sometimes due to the decreased levels of insulin like factor 1, calcitonin and estrogen. Vitamin K plays a main important role in post-translation modification of several matrix protein, especially osteocalcin. Also, this is released and it will enter into the blood and it will act upon your serum bone marker to predict the risk of bone fracture. Green leafy vegetables and oils and fats may provide vitamin K for older adults. Consumption of vitamin A is also considered to benefit the bone growth, whereas excessive intake of retinol especially may contribute to the risk of fractures. The dietary fiber, when excessive, also will interfere with the calcium absorption. Vegans who consume 50 grams of fiber are likely to have significant depression in the intestinal absorption. Thus, calcium with 1000 mg per day and vitamin D with 800 to 1000 units per day is being recommended as supplements for the patients. And remember to do the same for your patient who are being treated with bone drugs, as this is very sufficient and safe for bone formation. Before all this, you need to understand the different assessment methods. The most important assessment method is regarding the bone mass. The bone mass is actually a generic terminology which refers to bone mineral content and not the bone mineral density, BMD. BMC is used for assessing the amount of bone accumulated before the cessation of growth, and BMD is used to describe bone after the development period is completed. The peak bone mass is reached by 30 years and is greater in men than in women because of the frame size. Exactly at the age of 40, BMD gradually gets diminished in both the sexes, and after 50 years in females, the bone loss is great due to menopause. Bone mass decreases in men between the age of 60 and 70, the reason being the age itself, idiopathic or secondary conditions. The prevalence of osteoporosis and low bone mass in men is due to poor diagnosis as well. Apart from the bone mass, there are also an equipment to measure density of the bone using bone densitometry. The other one, which is abbreviated as DEXA, that is dual energy X-ray absorptiometry, and ultrasound measurements of bone. I like to summarize this module on osteoporosis. As I said, the use of bone becomes very essential as it performs the main function of building our body, and nutrients are very necessary in order to prevent the onset of osteoporosis. Always, prevention is better than cure. So, when a proper diet is consumed from your adolescent age and when you prolong it till the adulthood, the prevalence of osteoporosis can be minimized. Though this disease is very difficult to identify because it is asymptomatic, you need to advise your patient to take periodic check with the physician as the age processes, and also you need to advise your patients to adopt healthy eating habits that will slow down the bone mass loss, and always stress on the fact that this is going to help them to retain a peaceful life even after 40 years. Thank you.